can go ahead and start. I'll bring it on the show.
Thank you, wonderful. Well, then, let's start. So welcome everybody to the morning meeting organized by the Health Economics Division. Our topic for the day is strategies for non-communicable disease prevention and general well-being. And we've had two presenters. The first one is on the economics part, and the other one will be non-economics part. So we have Senzo talking about the economics of sugar tax and reducing non-communicable diseases, and he was sharing the lessons from Kenya, and by the way, this is his PhD thesis, so that's wonderful. And then Emeritus Professor Vicki Lambert also is our guest today, and she'll be talking about the physical activity of health intervention in the global south, structure and agency. Thank you very much for coming, and we'll start with Senzo.
All right.
We also have colleagues online, so we'll be communicating.
Okay.
Go ahead, Senzo.
Can you hear me online? Anyone?
Yes, we can. We can.
All right, great. All right, good afternoon, everyone. Today we'll be speaking about the not so important topic, but it is also important. The economics of sugar tax in trying to reduce non-communicable diseases, and we'll also touch on some of the things that we've done for Kenya and what Kenya can learn from South Africa and also other countries which have implemented the sugar tax. So why is this topic important? Sorry, just have to press here. So some background context to this. Non-communicable diseases have, according to WHO, have become relatively more common sources of illnesses and death. And WHO, the last statistics did indicate that about 60% of the death are attributed to NCDs, which of course 80% of those are likely to occur in lower middle income countries. And as a result, this was something which was very concerning and sparked a lot of our thoughts. Hence, I started a PhD on this topic. Of course, the unhealthy food and drink consumption has been identified as one of those modifiable risk factors for the NCDs. And there's been a lot of people moving away from, let's say, tobacco or alcohol and jumping into the SSP space because they feel there is a need to basically try and contribute to the research in cutting the spread of NCD as a result of sugary drinks. So while obesity has many causes, the overconsumption of sugary drinks is an important one that as health economists, we can at least use the public policy tools that we have to try and play our part. So if we go through the trend in sub-Saharan Africa, we see that there is an increase in obesity rates. In fact, if you look at South Africa, for example, it actually has the largest prevalence of obesity in sub-Saharan Africa, and in fact, one of the highest one in the world. And Nigeria is not so far off with also Kenya. So there has been an increase in obesity rate, which is attributed to, of course, the sugary drinks that are being circulated throughout sub-Saharan Africa. If you look at the global stats, although it's outdated, 39% of adults were considered to be overweight. And of those 39%, only 13 were considered to be obese. And that is something which, of course, over a period of time, it has gone up. So what I have here, this table depicts the BMI, and I put it according to whether you're a woman or a man. And as you can see, it's fairly normal for those which are underweight and the normal rate. But as you start getting into the overweight, you can see that women are largely more overweight than men. And if you look at the rates to obese, you can see that women are topping that chart. And as a result, something needs to be done about that. So in case you are still asking yourself, what is the link between obesity and NCDs? Well, most of the NCDs, when we talk about NCDs, we talk about heart diseases, most heart diseases, strokes, diabetes, Most cancers that are starting to be frequent, especially in sub-Saharan Africa, it's all part of the NCDs, and largely what contributes to that is the obesity. So, and as a result, WHO in 2015 came up with in a panel, in a meeting, where they said, because there has been an increase in NCD related death, governments in sub-Saharan Africa needs to take appropriate actions to try and reduce this, either by using the policy tools that they have, simulation models, so that they try and increase the retail price at least by 20% or more. But of course, in countries where the tax administration is not so strong, they should at least try to aim for a somewhat increase in tax that is going to be simple and easy for everyone to understand, which is volume-based SSP tax, and which is currently what Kenya has, and we'll touch on it. All right, so in relation to the fiscal measures to address the obesity issue that we currently faced with in sub-Saharan Africa, the WHO did indicate that you can use tax or price interventions, which is something that a lot of scientists have started to use to try and improve diet and prevent NCDs. We can also try to look at just how do we make these products less affordable. So, and there has been an increase in affordability of these. As you are aware, the relationship between an increase in income and the affordability of those. So as people start to move away from the lower income sector to category to the higher income category, they tend to afford these products easily, and they'll be able to buy many of those. So as economists, it's our jobs to basically look at that behavior and try to think about the fiscal policy tools that we can use to try and reduce the consumption. Of course, a lot of countries have an SSB tax. Some call it the fat tax, some call it sugar tax, and all of those. So we have more than 50 countries, states, or cities that have introduced an SSB tax. And for those that probably are still unsure what is SSB, basically we are speaking about the sugary that is in liquids, your Coca-Cola, your sodas, your concentrated juice or fruit juice, the sugar that is put in those liquids. So we have a term, what we call it, the sugar-sweetened beverages. That's what we mean by SSBs. All right. If you're still unclear as to if SSBs are bad for you, yes, they are. The Minister of Health in South Africa did indicate at one point that these are empty calories. So if you are thirsty, you take a soda and drink it. You basically have not done anything that is needed by your body. You are just drinking something because of, let's say, you want to drink it, but it plays no role in what your body currently needs. So our body processes liquids differently than sugar in food, especially those containing fiber, like fruits. In fruits, the sugar is packaged in fiber, whereas in SSB, it becomes very difficult for the body to digest this. And the sugar is thus released more slowly into the bloodstream and stays longer, and it's basically bad type of sugar that you need. All right, so in liquid form, more sugar goes to the body's vital organs than the body can handle. And this will, of course, lead to an overload in your pancreas and liver, and thus contributing negatively to the progress of your body. So basically, this is just to answer if sugar is, SSB is worse than the sugar in other form, in case you are still not sure. But I thought I should just demonstrate the amount of sugar that you're most likely to find in your liquids. If you look at most water, no sugar. But as you look at, let's say, Coca-Cola, you can see the amount of sugar. If you look at it at the back, it's about 35 grams per can. And that shows you that if 1 teaspoon is 5 grams, that's about what, seven teaspoons? So as you buy these products, you are able to see how much sugar you have you are drinking at the back. It's basically just the actual raw sugar which they put in there. So you're basically just drinking sugar. And this is not what we want. So we want to try and get people to move away from these products and go to at least water or those which don't have sugar in it. Okay, so what is the current situation in Kenya? Right, NCDs account for more than 50% of the total admissions and over 55% of hospital death. If you look at the overweight and obesity rate, which have increased from 25% in 2009 to 33% in 2014. And in 2015, about 39% of Kenyan women and 17.5% of men were considered to be overweight. And this then rang a lot of alarms in Kenya, because if you look at the trend, it has slightly been going up. And they developed something called a national strategic plan, which they looked at all the risk factors which they currently have. They focused on tobacco, the harmful use of alcohol, overweightness and obesity, unhealthy diets, and of course the physical inactivity and environmental governance. So these are the type of strategies they came up with and said, let's try and get more research and data so that you can at least make informed decisions on this and try to at least reduce obesity or NCDs through this the national strategic plan. All right, so currently Kenya has 10 Kenya shilling excise tax on all non-alcoholic drinks from 2018. But the only reason why they implemented that was just to generate revenue. It had nothing to do with public health. And that's not something which we are trying to propose to say, let's have an excise tax that is just geared to public health. So there's no incentive for the manufacturers to reduce the sugar content, and you can see why that is important. Look at the BMI. 14% of male and 10% of females are classified as underweight. But we are largely interested in those here, which is 25% of females are overweight and 40% are obese. Of course, over time, these figures have changed. They've gotten up. So there is a clear difference in the BMI distribution between male and females in this case. Of course, if you compare it to South Africa, it's still not at that level, but there is an increasing trend of women being overweight and obese in Kenya. All right, next, I'm just going to briefly talk about one of the paper that was published with colleagues from the School of Economics, where we looked at the likely fiscal and public no sound. Can you hear me now? Anyone?
Yes, we
We
can.
can hear you now.
All right, sorry about that. All right, so the aim of the paper was really to investigate the likely impact of an SSB tax on prevalence for overweightness and obesity by looking at just trying to understand the SSB consumption patterns over a period of time in Kenya, and then using that to basically calibrate and create a simulation model to see if Kenya were to propose two policies of SSB, what would happen to your BMI, what would happen to government revenue, of course, and other things. So what we did was to use Euromonitor data, which, of course, the limitations for it is that it largely focuses on retail outlets, formal retail outlets, doesn't really go to the informal sector. So we asked the colleagues based in Kenya to try and compare and see and give us the data so that you can get averages for that. And then, of course, we use some of the data which we got from Sin and friends. So ideally, the model is like this. It's quite technical, but I'll try and explain it as much as I can. So you start off with an introduction to an SSB tax or an increase in an SSB tax, because you understand the consumer behavior that there is what we call, if let's say a person is thirsty and wants to go and buy, let's say Coca-Cola, the only thing they're interested in is actually the price. So if they go to the store, they only look at the price and see if the price is something which they can afford or not. So if you change that, looking at the law of demand that we know in economics, and also taking into consideration the substitution effect, because we understand that we're trying to get people to move away from these unhealthy products and move away to substitute to healthy products, which we're assuming those are supposed to be cheaper. So if you make this one expensive and make this one cheaper, the rational consumer is most likely going to go to the cheaper one. So taking that into consideration, of course, there's a lot of things, the parameters that go into this. And then you will have your net effect, which is going to reduce the consumption. Once you have your net effect, then there's going to be a change in PMI. We've categorized this in different groups, age groups, and then you're assuming that there's going to be an impact. At least it's going to go down to your PMI. On the other hand, as the government increases or introduces an excise tax, they're going to generate government revenue. So you're going to have at least some level of money that goes to government, but that's not the intention. Really, the intention is to try and curb the spread of NCDs. But of course, in itself, but it's going to generate some money. Another thing that I want to focus on really is the product reformulation. So what we mean by this is we're going to have an example in the next slide, where you are trying to also, as you introduce this sugar content-based tax, you are trying to make the companies that are producing this product to at least reduce the amount of sugar that they put in. And when I see an example of that. So the model basically accounts for all of that. It's geared for that. So we have two excise tax scenarios. The first one is there is no tax exempt. Everything has to be taxed at 0.3 Kenya shillings per gram of sugar. So if you look at it in relation to just 1 liter and content of 10 grams per 100 milliliter, there will be 0.3.100 grams, which is basically like 30 Kenya shillings. And then the second one, that's when you say, like what we currently have in South Africa. If you're, let's say 1 liter, up to a certain point, you will not be paying tax. But should you go above this threshold, then the tax will be implemented, which is currently what we use in South Africa. Because that basically says you want to get companies to say, oh, at least if I produce anything below the threshold, I'm not going to be taxed. So you're trying to reduce the amount of sugar that goes into this product, so that and either way, it's a win for public health. And we've seen this with South Africa. If you look at these are all the common brands. I'm not sure if you can see, these are all the common brands in South Africa. If you look at before the tax which was implemented in 2018 and after, this is the amount of sugar. What you see in blue here is the amount of sugar that were in the product. But post the excess, the sugar tax, this is how much sugar you get in each of these now. Because why? Because we understand that the companies are profit motivated, and they know that if we go above this threshold, we're going to be taxed. So let's rather put sugar that is below this, which is also still a win for public health, because that's basically what you want. So these are just the before and after to show you that if you implement a policy that is targeting the sugar in these products, there's actually a big difference. So in the paper, these are the results before the excise tax. Currently, there's 10 Kenya shillings, and if you introduce now 19.5, just the SSB tax, you are likely to have the retail price, which we said the consumers react to, which is going to increase by 23%. And if you go to a store, you want to buy a can of Coca-Cola, you're saying, oh, the price have gone up, assuming there is a 100% pass-through, which is very important. By pass-through, what we mean is that if the government increases the tax by 10, you are assuming that the companies producing this product, as by 10, I mean 10, let's say 10%. You're assuming that these companies which are producing this product are going to take the 10% of that tax and pass it on to the consumer. They're not going to take some, which we've seen in some cases with tobacco and alcohol, where at least in the short run, they would say, because they're trying to make their products more affordable, which is cheaper. Because for them, when it becomes cheaper, a lot of people are going to consume it. So, and as the government, you are not trying to make the product cheaper. You have to make it expensive so that the rational consumer will start looking at, should I really be consuming this or should I go to something else? So there's going to be a 23% increase. Of course, the increase must not be so big that it will cause problems, especially in the case of Kenya. You just know that they rejected the finance bill. Tax is a big topic. It's a very sensitive topic. So the government needs to see how to maneuver that political climate. And this is scenario one when there is no threshold. This is scenario two when there's a threshold. So scenario two, there's a 14% increase, less than the first one. But what you are trying to get out of scenario two is to reduce the sugar that goes into these cans significantly. And then consumption, by doing that in simulation, we get to see that if, let's say, in a single year, Kenyans were drinking about 2.2 billion liters of sodas. Once you've introduced scenario one, they'll be drinking 1.7 billion, which is a reduction of 20%. In scenario two, there's a reduction of 13%, but it's not really about the liters that they drink, it's about the sugar that is in these cans. With scenario two, the sugar is going to reduce significantly because that's basically what you want. So as I round this off, in relation to the public health, the obesity, we've disaggregated this into males and females, where you can see the weighted average. Basically, there's a decrease, because this was the baseline. This is before the introduction of the sugar content tax, and this is after. So you're still getting some level of reduction in this, and that's what you want, because basically you just want to ensure that at least the population is healthy, they're consuming less sugar, because sugar is really bad for us. And then, of course, this is for females. This is goes from 32.2% to 29.6% after the tax. And this is just for the overweight, but look at those that are obese. They go from 3.1% to 2.1%. Someone will say, that's not, that's still a lot of people. At least you try to get the BMI to be a lot of people to move away from being obese to at least to the normal BMI. And the same can be said with the females, 8.4% to 7.4%, without any waste of time. As I conclude, now, it's not something which the Kenyan government can wake up and say, we're introducing this tax, things are going to be fine, and that's it. There is going to be a lot of backlash. The industry responses, if we've learned anything from tobacco or alcohol, is that there is no industry that likes to be targeted for health taxes. We know this. And in fact, if we know anything in South Africa, the industry always oppose the tax. They fund politicians, they fund programs so that they can try and basically get the government not to pass these taxes. They will always use typical arguments such as jobs will be lost to the GDP, and the tax will hurt the poor and things like that. But all of these arguments can really be debunked, such that the government needs to really state their intention as to what is important is public health or these products which are destroying or at least increasing NCDs, where you have hospitals which are full because of these harmful products. So in conclusion, a sugar-based excise tax on SSB can play a significant role in reducing prevalence and overweight in Kenya. So the current excise tax on soft drinks reduces the demand for SSBs, but does not significantly target these products because it's just a blunt 10 Kenya shillings, and 10 Kenya shillings is really nothing. So the supply response to a sugar-based SSB tax is likely to be greater than the demand response. And as a result, we understand that just by introducing an SSB tax, it's not a silver bullet. There's still quite more that needs to be done in terms of administering, trying to get which of these products are new and where they're coming from and illicit products and things like that. So we understand that just introducing an SSB tax is not basically everything. So my last slide, just a take-home message from this seminar. The government of Kenya should consider implementing a sugar-based SSB tax over and above the current 10 Kenya shilling they currently have a litre per excise tax on non-alcoholic products. So the primary aim of an SSB tax is to enhance public health by raising additional revenue, but that should not be the first or the primary aim of the tax. So it should be focused on public health, and anything else comes secondary. If it is designed properly, an SSB tax can reduce both the demand for and the supply of SSB. An SSB tax should not be seen as a miracle. As I did say, it is not the silver bullet that just because you have this, everything is going to be okay. Understanding obesity is really a complex and multifaceted issue. So it needs to be addressed in a holistic way, and all things needs to be considered. So, all right, that's all for my presentation. Thank you.
Very much, Senzo, for a very interesting and insightful presentation, and good luck with your PhD going forward. We'll just take one question from the room and one question online before we move on to the second presentation, if that's all right. So any hands here? Online says, if you don't mind, just check.
Any questions online? Leslie, yes?
So it's not a question really, it's just a comment. I use this issue of taxation in teaching on human rights and public health. And we had a student who did such a good assignment on it. She then taught it for a while to the students in the MPH. And she did this exercise of asking students to bring in soda cans and then calculate the amount of sugar. And they all fell off their chairs as you showed the amount of sugar in sugar-sweetened beverages. But I do think it does raise the issue of regulation as something that limits rights. It's actually company opportunities for livelihoods. And that's an important trade-off in the interest of public health, but obviously it's something worth doing. Maylene and I are having a little discussion on the side about whether the decline is too big or just right in obesity. But you can pick that up if you want. Thanks.
All right, thank you so much for that comment.
Some more questions we want to take from Rena.
Yes, Rena, can you come in?
Thank you very much for the presentation. More comments than actually question. the issue that we experience in South Africa is that with the threshold, companies did actually not reduce the sweetness of the beverages. An unintended consequence was that they increased the use of artificial or non-sugar sweeteners. And that is going through the roof. And that's actually the reason for the change, the dramatic reduction in the sugar content that you illustrated on your slides. And then secondly, there are alternative strategies followed by industry, other than, where they don't transfer the cost and that's what they did in South Africa. They changed the volume of the containers so that on the shelf, the price remained exactly the same, but the one container was like 2.25 liters, and the other one with the sugar was 2 liters. And consumers don't pick up those differences. So, it's not always, company responses are not always as clear and as ideal as you suggested. Thank you.
All right, just to add on that, that's a very important comment. The industry is always ahead. If we are being honest, this in most cases, these are multi-billion-dollar industries, which they've been doing this for years, and especially for SSBs, which really just started to get on board and tackling this one from the public health perspective, but they are always ahead. So our job really is to try and get and trying to understand them, how they do things, also how they move. And we can learn a lot also from just the tobacco and the alcohol industries. But yeah, they're always ahead, and they like complicated tax systems because for them, it's easy for them to change things. And South Africa, of course, did not foresee that if they introduce this, of course, the level of sugar will go down, but those artificial sweeteners will go up. So they're always ahead, always looking for the next strategy, basically. So our job as researchers is to follow up. Right. You had a comment or question?
No, thank you, Ms. Kabatani.
All right. Any other? Oh, I see there's Meilin. Yes, please.
Thank you, Senzo. Can you hear me?
Yes, we can.
So just at a policy level, we did a little policy analysis on diet-related policies and sugar-sweetened beverage-related policies. And I think part of the issue is that many of the companies that you're referring to are global multinational companies, and it shouldn't be incumbent on a single country to have to fight the battle with these industry giants, as it were. And the WHO policies are very tentative in, very clearly prescribing, and the World Trade Organization policies are equally tentative in taking on these industry giants. So it then becomes each country's mission to engage with these companies that actually operate across the world. So we also should be advocating for global initiatives like we try to do with the tobacco control initiatives to tackle these agencies at a global level, because many smaller countries don't have the capacity to take them on, and then all those conditions that you illustrated in your slide that they offer as excuses or reasons for not reducing sugar then just continues in those smaller countries. Yeah, so that's just a comment I wanted to make.
Right. Thank you so much for that. Absolutely, that is correct. I think we are starting to see a lot of at least initiative from WHO, World Bank, and other global institutions to try and assist to those countries, and like how they've done with tobacco and alcohol. But with SSB, of course, it may still take some time because it's not something which a lot of people are familiar with. So yeah, definitely those global initiatives and collaboration are needed in trying to tackle this. Okay, thank you so much. I'm going to hand over to the next speaker.
Sorry for
It's-
cut you short there.
Sorry.
Thanks very much. Thanks also for the invitation. And I'm going to go speed through the talk because it's more to just give you a flavor than it is specifics, if that's all right. And I'm really going to be talking about physical activity, hopefully in a slightly different way, from a health promotion and also health economics, and also from a burden of disease approach. So just going to give an overview of the prevalence of inactivity, or what we regard as insufficient activity, and then sort of turn physical activity into a slightly different conversation around sustainable development, and how it essentially looking at it more as a rights-based issue, and how we can and should be changing the conversation, because if it just sits in the health domain, there's really been little change in physical activity prevalence over the last 20 years. And it's, I think, because the conversation has largely been around health and not in the focus of development, and also from a rights point of view. And then talk a little bit about physical activity security, and then to give you some idea of initiatives that are happening in the Global South, and who or what might be the practitioners for promoting physical activity, who are the assets, community-based and other assets, that we could actually mobilize to actually assist with this. So this is just some indication of the global prevalence of insufficient activity. Now, this is based on the WHO and their guidelines up until 2020, which was about 150 minutes of at least moderate activity on most days. The WHO now recognizes literally that any physical activity actually is health enhancing, which is fabulous on lowering the barrier of entry into care, but it's super complicated from actually coming up with surveillance, because it actually makes the issue of surveillance quite complicated. But based on the existing or the current guidelines, basically about close on 28% of the world are insufficiently active. And there is a gender disparity. But what's actually more concerning than anything is that there's literally been no change in prevalence. If anything, in high-income countries, it's actually decreased, and we actually regard it as a flat line. So through all the promotion of physical activity, through all of the sort of WHO actions, and even World Health Assembly and in-country activations, there's been literally no change. So why is it important? Well, again, in the sub-Saharan region, about 30% of the burden is NCDs. Nearly half of adults have hypertension. There's over 20% who are obese, and there's a greater than 5% prevalence of type 2 diabetes. Again, a large proportion of people on the continent, despite the fact that we have the most active continent, are actually not meeting guidelines. And there's actually there's a paucity of national physical activity plans. It's actually been sidelined in favor of what are regarded as more urgent health agenda issues. And another issue in our region is that there's lack of equity, gender equity, and also there's actually risk to personal safety and other barriers to physical activity. This is a paper which was published in 2022, which looked at physical inactivity with respect to the burden of disease in South Africa. And while it doesn't look substantial, that about 2% of deaths can be actually accounted for or attributable to physical or insufficient physical activity in South Africa, and about just over 1% of the daily adjusted life years. And the large proportion of these dailies come from, for example, diabetes, ischemic heart disease, and stroke, colon and breast cancer. So it clearly is a health issue. This was a scoping review which we did, or we're in the process of doing, looking at physical activity and it's associated, what it was associated with. And this is looking at publications from 1990 until just over 2020. And you can see that these are the publications that are associated with physical activity cross-referenced with health. This is looking at it as a behavior. And so when we think of behavior, we think of individual, we think of health messaging around that, and we think of sort of how you can actually help that individual alter their behavior. But it's only, and also as a risk factor for these chronic diseases. But the growth of the literature and the understanding of the upstream determinants of physical activity, the fact that you need an activity-supportive environment, or for example, that the social determinants of physical activity may be actually very important, or issues around equity have hardly shown an increase. And so there's really been not a sort of an important or active agenda in looking at physical activity and the upstream determinants, giving all of the responsibility to the individual rather than actually looking at the environment in which the individual is situated. Moreover, we haven't looked at physical activity specifically as a development issue. And this is an indication of the Sustainable Development Goals. And what you can see is that basically physical activity or inactivity or increasing physical activity levels can actually contribute not only to health and all, but it can actually attribute to poverty reduction. It can actually contribute to quality education, life on land, resilient cities. Almost each and every one of these Sustainable Development Goals can actually have a link with increasing physical activity levels if we actually consider it in that way. Again, life on land and so on. And the other really interesting thing is that the UN agencies define the word development as processes that enlarge people's choices. And I don't think that we often think about that. When we think about development, we think about technology and we think about those sorts of things, but we don't think of it as actually something that actually increases the choices of individuals who are typically choice constrained. And particularly in a country like South Africa, where we have a huge amount of inequity, that's actually important. So around the whole physical activity, we have colleagues who are actually looking at physical activity, and they try to actually frame it as necessity-driven or choice-driven. And so they think of necessity-driven as, for example, active transport, walking or cycling to and from places because someone has to for their job, or active labor, occupational physical activity. But they have framed leisure time or recreational physical activity as choice-based. Now, how many of you who would actually choose to do physical activity, for example, walking in your neighborhood in the evening, if you felt safe? So the notion of leisure time physical activity being choice-based only, we feel is incorrect. We think that then assumes that basically you can make choices even in the absence of a supported structure. And we think that is, we don't agree with that framing, and I'll explain that in a moment. So these are data from one of my PhD students, Pastor Malombo, looking at, for example, the odds of leisure time physical activity. And so proximity to destinations, retail destinations, transit hubs, having pleasant scenery, sidewalks, shade, safety from traffic, well-lit streets. All of these factors are associated with increasing levels of physical activity. But for example, when we think of public open spaces in South Africa, we have some of the most beautiful public open spaces on the continent probably, but it's very inequitably distributed. And what public open spaces mean to some people in certain areas and neighborhoods has a different context than it might have, for example, in Kirstenbosch, and where you actually have to pay rates or pay a high level of entry. We've also looked at other ecological factors, these upstream factors, and this is factors also looking at the odds for meeting physical activity guidelines. And one of the most interesting variables that we have not been able to get rid of in any regression is litter. And that when you have the absence of litter, that actually increases people's odds of actually doing physical activity. And we're not sure whether litter actually refers to the absence of the state or social disorder. But either way, it's something which we cannot get out of our regression that's significantly associated. And again, if you have proximity to transport or proximity to shops or retail destinations, all of those are associated. Conversely, and this is an ecological study which was done looking at traffic deaths in low-income countries in Africa, lower middle and upper middle income. And there's in this case, again, this is the traffic deaths, and then this is inactivity. So the closer it is to the y-axis means the most inactive. And what we find is that the most active countries are the ones with the highest traffic deaths. Okay, the low-income countries. And again, that suggests it's utilitarian. People are actually moving about because they don't have a choice. They don't have access to their own vehicles. And on the other side, this is looking ecologically again at the crime index. So we have a crime index on this axis. And again, the higher this value, then the greater the level of inactivity. And only in the upper middle income countries do we see an association. So crime is only a deterrent when people have choices. When they don't have choices, It's not a deterrent. They have to walk anyway. They have to actually move from place to place. So we've working with a new definition, which is physical activity security. That is when all people at all times have physical and economic access to sufficient, safe, and enjoyable physical activity to meet just not health needs, but also to promote social, physical, and emotional well-being and social connectedness for an active healthy life. It's very similar to the definition of food security, but it's largely ignored from a policy perspective. So we did our own ecological study, and we looked at publicly available data, the Worldometer, our Walden data, and the WHO repository. And we tried to actually look at some of these factors it's about a sample size of about 147 countries. And so clearly we're looking at high income versus the low, middle, and upper middle income countries. And we found, not surprisingly, that in the lower middle income countries, we have less physical inactivity. And then deaths due to CBD are obviously lower, where there's almost a doubling of deaths due to road accidents, for example. Deaths due to violence double, life expectancy significantly lower, food insecure, so higher in the LMIC's proportion of obesity. So all of the factors that, not surprisingly, are associated with either being a high income or lower middle income country. And if you look at the land allocated to public open space, that's POS, you can see there's a vast difference, and similarly access to public transport. So already we're seeing kind of an inequality in the society or in the sort of geospatial environment. So we then looked at the correlates, these correlates against, so physical inactivity is on the y-axis in each of these cases. So the higher, the less active the society is. So as a country urbanizes, there's less physical activity. But if there are slums, the more slums, then the greater the physical activity. So slums are associated with greater physical activity. Human Development Index, less physical activity. If you look, for example, at traffic deaths, again, you have a clustering here around countries which actually, in terms of physical inactivity, and food insecurity also has a similar pattern to slums. And so you're seeing this rather sort of inverse association. Even, for example, percentage land share of public open spaces. The more public open space, the greater the inactivity, which is counterintuitive. If we break it down and we disaggregate it, this is looking at that relationship in the lower and upper middle income countries. So in these cases, the percentage land use for public open spaces, in this case, is positively associated with inactivity, where people can't get to and from places using their own vehicle, whereas in high-income countries, it's less associated. So in high-income countries, public open space is used for the purpose for which it was designed. And where in the lower middle-income countries, we don't see that. And again, when we look at the regression overall, we can look at Human Development Index, we can look at public open spaces, the interaction thereof, and also percentage urbanization. And so countries with lower HDI are more active, not surprisingly. And in fact, well, and we said urbanization and even air pollution is positively associated with inactivity, but this public open spaces interacts with HDI. So, and I'm just going to go in terms of time. So when we think of the construct of walkability, which is something which has been defined largely for the global north, it may actually be different in settings which are highly unequal. So this is our definition of walkability, for example, is residential density. One might argue that this is more residentially dense. Street connectivity, one might argue that this is greater street connectivity. Destinations. But I would argue that a lot of people would not feel comfortable walking in this community and would not feel safe. And so we need to actually think about adopting these global north definitions in the context of our settings and actually try to reframe the conversation so that we can actually look at co-creating activity supportive environments. So to finish on this is to focus on what are the solutions? How do we attack this? And the World Health Organization in 2020 formulated the Global Action Plan for Physical Activity with really 4 distinct policy action areas. And it's incredibly well described. And it's something which is really a roadmap where you can look at changing the attitudes and social norms around physical activity, around active societies. But the upstream focus is on these environments, creating these active environments, and then also active people. So that is programs that can be implemented at the community level. And then finally, active systems, which would incorporate policy. And so I'm going to just give you a few examples. The International Society for Physical Activity and Health have created 8 areas that are evidence-based. So these areas are evidence-based and show that if you implement interventions in these 8 different settings, that you will have a positive impact on population-based physical. And that includes active transport. So a good public transport system and actually a cycling and walking network. Active urban design so that people can actually safely walk to and from and also recreate in public open spaces with lighting and safety. In the healthcare sector, making physical activity part of the training of both medical and allied health practitioners. Public education and mass media programs that are supported by community-wide programs. Whole of school programs, one of the cheapest ways to intervene for physical activity. And it can be embedded in the system and the workplace and sport for development. So just to show you how successful this can be, this is something known as Ciclavia and Recrevia. And these are programs that are based in the Global South, primarily in began in Colombia and also in Brazil. And Ciclavia, for example, has been going now, gosh, this is now 50 years. This began in Bogota, Colombia. And at present, every Sunday and every public holiday, 120 kilometers of city streets are closed to vehicular transport. And members of the community can actually use these streets for recreation, for walking and for cycling, for skateboarding, or whatever it is they want to do. And it's a massive undertaking, but it has actually become a global phenomenon. And there are open streets and Ciclavia examples in every continent at this stage. But what it has done is it's actually, and this is also their public transport, which is not unlike our My City, but it's reduced car dependency. It actually is increasing property value in the areas that are associated with these walking tracks, as well as actually decreasing crime. But it's also impacted on meeting physical activity recommendations, that it actually increases, measurably increases the prevalence of physical activity. And it's even been shown to be a benefit to cost ratio of 3.23 to 4.26. So huge benefit. And what about Recrevia? This is actually physical activity classes that are held within communities by trained physical educators. And this is something that is funded by the government of Brazil, which quite frankly is not that much better off in terms of its Gini index, Gini coefficient than South Africa. And it also happens in Colombia. And we're looking at, for example, that these are run 6 days a week for 2 to 7 classes or hours every day. And they tried to remove the program because of the cost. And there was a massive outcry. And it's a very simple thing that's done within communities. And in fact, I heard yesterday that the DCAS, Department of Culture, Arts, and I can't remember the acronym, has actually made facilities available for the Western Cape on Wellness champions to actually use their facilities to run programs. So we are approaching this. We are approaching this, but it's a volunteer program. It's not something where it's paid for. But this is now moved on to 7 countries in Latin America and over 350 physical activity classes. Another area that we're looking at is outdoor gyms. And again, because of time, I'm not able to go into this in any detail, but we've been surveying about 10% of the outdoor gyms in the city of Cape Town to find out if they're being used for the purpose to which they were designed, what the state of those was, and what is the satisfaction with these gyms. And so one of the interesting things is that they're not designed for children, but over 50% of the people we observe in these gyms are children. And they're not using them as gyms, they're using them as playground equipment, which is not a problem, but it might argue that, in fact, maybe there needs to be more playground equipment provided rather than gyms. And we also did intercept surveys, looking at the reasons for outdoor gym use and so on. And so, for example, people actually travel more than 1 kilometer and often actively, that is this walking and cycling, to access the facilities. And so we were able to account for about 87% of the variance in gym use by just simply the number of stations. So the more equipment, if you're going to go into just like 4 stations, that's not going to give anyone a workout. But where there are the most number of stations, even if some of them are not functional, there's greater use. And if we look at, for example, again, kind of a scary concept, if there are crime events in the area, the gyms are more likely to be used. So what we're finding is that the gyms that are in the low-income communities that have a lot of equipment become a social hub. People are going there. Whereas the sort of gyms that are sort of scattered in the leafy suburbs that have, say, a handful of equipment are not being used because people have choices. And so where should the city be investing? It should be investing in the areas where people actually can create a safe space within a non-safe area. And that's one of the recommendations to the city. And then my final comment is, who are the practitioners? And just so you know, there are over 450,000 educators in this country. If we were to actually create just a small amount of sort of intervention for educators to actually be promoting physical activity in the school environment, then we actually have a massive opportunity. We know that school-based physical activity, if it's physical education and quality physical education, and even just activity breaks, are associated with better academic performance in schools. Even in schools in South Africa, there is evidence to that. So again, it goes to, that's me. What about health champions and wellness champions? So community health workers, for example, and non-stipendiary wellness champions. These individuals help to provide a contextually appropriate physical activity intervention. And so there are over 70,000 community health workers in this country who could actually also be implementing physical activity. And for example, the government's document Health for All as a training tool actually has some focus on physical activity. We're just not measuring its impact. There are over 1,200 wellness champions that have been trained by the Western Cape on Wellness Program in the Western Cape alone, non-stipendiary volunteer community champions who are on an almost daily basis implementing physical activity within their communities. There are only 1,600 biokineticists in the country, and these people are highly trained, but they're trained at a level for intervention largely, for example, in clinical physical activity, but they could be deployed, for example, in schools and communities in a different way. There are about 1,300 registered physical trainers in this country. But here's the kicker. There are over 55,000 parkrun volunteers. There are almost 1 million finishes every week on a Saturday. There is no government initiative that is of this scale, and this is an entirely volunteer initiative. Why are we not capturing that in some way, and why are we not harnessing that for physical activity promotion? And even the walking school bus. This is an initiative which started in the city and actually was taken over by the province or the other way around. And basically, again, about 90 areas, there are volunteers from the community that walk kids to and from school to make active travel to school safe. And again, largely volunteers. So I'm going to finish by saying that physical activity security, to achieve it, means that we have to reach equity, or we have to get equity. So agency may be the capacity of the individual to act, but structure is the recurrent pattern arrangements that influence or limit those choices. So agency for physical activity can only be realized in a supportive structure. So my feeling is that we have to be a little bit careful about talking about behavior and choice without considering this notion of structure, that physical activity can only be equitable if agency and structure both achieve. So thank you very much.
Thank you very much, Vicki. We have a few more minutes left for questions. First in the room.
We have lots of projects that people want to collaborate. We need help.
So let's see if there are any questions online. Any questions from the colleagues online? Comments? Okay, in that case, I'm going to say thank you very much to the presenters, Senzo and Vicki, and to everybody attending our noon meeting. I'm going to stop recording. Goodbye, everybody. Thank you. Make sure that I stop recording. Here we go. Wonderful. Thanks again. Thank you, everybody.